with the acromioclavicular joint. Acromion is part of the scapula. Most fractures occur from simple fall on the shoulder.
بس سوي شير للمحاضرة ولو يا ليت تخليها فول سكرين كذلك عشان توضح لنا.
ما هي ظاهرة عندكم؟
لا.
والآن؟
اللي ظاهرة يا دكتور.
طيب, most of the fractures are in the middle third, some of them in the lateral third, and very rarely it will happen in the medial third. So clinically, you should check for skin tenting, which means, the spike of the bone is, tenting the skin, and that might lead to risk of breaking down the skin. Also, it's very important to check for brachial plexus injury, subclavian artery and vein injury, and rarely you might have pneumothorax. This is an X-ray of a minimally displaced clavicle fracture. So if you have minimally displaced fracture, you can treat it non-operatively with a sling. The only fractures that needs operative fixation is open fracture, if there is skin tenting, and if there is complete displacement of the fracture, and then you need to do open reduction internal fixation with plate and screws. Proximal humerus is also a common fracture. There is usually more than one part. There is the head, there is the greater tuberosity in red, there is the lesser tuberosity in green, and there is the shaft, and there is two necks. There is the anatomical neck, which is the one here in white, and there is the yellow line, which is the surgical neck, which is the most commonly injured. So surgical neck is less risky for damaging the blood supply to the head, while the anatomical neck carries high risk of osteonecrosis of the humeral head. So usually it happens in young and elderly patients, young patients with high energy trauma and elder patients with minor trauma. Most fractures are minimally displaced. Physical examination, so you have to expose the shoulder very well. Look for fracture signs like ecchymosis, swelling. Check the skin for any breakdown. Do a good peripheral neurovascular examination. Axillary nerve is commonly affected in proximal humerus fractures, and also examine the joint above, which is the cervical spine. This is the area of the axillary nerve innervation. You have to examine it. And then these are the special X-rays for proximal humerus fractures and shoulder injuries in general. Axillary view is very important, and as you can see here, it shows you whether the joint is in place or not. There is a classification called Neer's classification, classifies the fracture based on the displaced parts. So to call it a separate part, this part should be displaced more than 1 centimeter than the other pieces. So in this case, we have 4 parts. If each part is 1 centimeter away from the other, then this is a 4th part fracture. If only one piece is away by 1 centimeter or more, then this is called 2 parts fracture, etc. So this is an X-ray here, shows you a normal proximal humerus. But when you get the other views, you can see that there is, a greater tuberosity fracture that was not clear on the AP. And sometimes you might have, very obvious fractures. You can also diagnose them from one view, but still this is not enough. So this is, probably 2 or 3 parts proximal humerus fracture with significant displacement of the shaft. So treatment. If the fracture is not displaced, treatment with a sling and non-weight bearing for up to 6 weeks will be sufficient. Early range of motion after 2 to 4 weeks is important to restore the patient function and resume activities, usually within a few months. So if you have significant displacement, so surgery is usually indicated. You can do it with plate and screws, as you can see here. Sometimes if the damage is severe, you have to do arthroplasty, which is hemiarthroplasty, means replacing just the proximal humerus part and let it articulate with the glenoid. Humerus shaft fractures can be classified based on location of the fracture, so proximal, middle, and distal thirds. Always look for fracture symptoms. Check for skin, neurovascular examination, compartment. Watch for radial nerve palsy, because it's usually common in this kind of fractures where the radial nerve travels in the spiral groove. This is an example of a spiral mid-shaft humerus fracture. This can be treated conservatively with a splint, functional brace for 4 to 6 weeks with non-weight bearing. After that, early range of motion of the elbow and the shoulder. Surgery is also indicated if you have a segmental fracture, open fracture, obese patient who cannot maintain a good alignment with the brace, bilateral fractures, floating elbow. In this case, usually the way of fixation is plate and screws. Both bone forearm fracture is usually common, and most of the time both bones are injured because they are connected in one circus, and if one bone is fractured, the other one will be also injured. Because they articulate with each other proximally and distally, it's very unlikely to fracture only one bone, as we mentioned, without disruption of the other articulation. So you have both bone fracture, where both bones are fractured at the same level, Monteggia fracture and Galeazzi fracture. So Monteggia fracture means proximal or middle third. Ulna shaft fracture with dislocation of the radius proximal at the elbow. So this is an example of a Monteggia. So proximal ulnar fracture with displacement of the radial head can be anterior, posterior, or lateral. This is an example of a lateral displacement. This is called Galeazzi. So distal third radius fracture with dislocation of the distal radioulnar joint. This is also an example of Galeazzi with posterior dislocation of the joint. So clinically, check the same thing. Check skin, signs of compartment syndrome. Check the neurovascular examination. Get appropriate X-rays, 2 orthogonal views. Usually in a both bone forearm fracture, you need to reduce and splint, and most of the time they need to be fixed surgically, especially in adult patients. In Monteggia and Galeazzi fractures, once you fix the fractured bone and you get it out to length, the joints will reduce. Example of Galeazzi fracture after fixation. Distal radius fracture is the most common fracture of the upper extremity, most frequently seen in elderly women. Young adult fractures are most commonly secondary to high energy. The mechanism of injury usually fall on an outstretched hand. They call it foosh, F-O-O-C-S-H. Foosh, fall on an outstretched hand. And then there is extra-articular and intra-articular. Extra-articular, if it's displaced dorsally, they call it Colles, and this is the most common. And if it's displaced volarly, they call it Smith, and this is less common. If it's an intra-articular fracture, it can be a volar lip or a dorsal lip, and they call it Barton's fracture. This is an example of Colles fracture, extra-articular with dorsal displacement. This is Smith fracture. There's an example of an intra-articular fracture, either dorsal or volar. Very unstable fractures usually require surgery. These are other illustrations to explain the direction of the fractures and the different naming. So this one on the left, this is the colles because it's displaced dorsally. How do you know where is dorsal, where is volar? From the thumb. See, this is the thumb. This is the thumb here. So the thumb is usually volar, and I know that this is dorsal. Here, this is a thumb, so this is volar, and this is dorsal. So this is a Smith fracture. So treatment, if extra-articular, most of the time reduction will be successful and will be enough. If you still have shortening or displacement, surgical fixation will be indicated. In intra-articular fractures, most of the time, because it's unstable, it requires surgery with plates and screws. These are some examples of, plates and screws in the distal radius, and this is a full cast immobilizer for a distal radius fracture. Any question about upper extremity fractures?
لا يا دكتور شكرا.
طيب. Hip fracture, the most common fracture of the lower extremity, usually osteoporotic patients. Most common mechanism is fall from standing height for elderly patients, usually because of stroke, MI, and it's very important to evaluate patients for this. This can be a life-changing event because the mortality rate is very high, especially in a very old patient. So we have intracapsular and extracapsular fractures. Intracapsular, like the head, neck, extracapsular in the peritrochanteric area and the subtrochanteric area. And also you can describe it based on the amount of displacement. So intracapsular fractures can be divided into subcapital, means just below the head, or transcervical in the middle part of the neck. So there's a high risk of avascular necrosis, which is disruption of blood supply to the femoral head, and therefore in elderly patients, it's better to replace the broken part with metal, so hemiarthroplasty. In a young patient, you have to rush the patient and do urgent or emergent open reduction tendon fixation. Take detailed history, rule out syncope, other causes of the fall, assess a deformity, usually it's abduction, external rotation, and shortening of the limb. Assess always for the neurovascular examination. These are some X-rays, AP pelvis, and you can see that there is a femoral neck fracture. So I always get AP pelvis, hip X-rays, AP and lateral. These are the AP hip. This shows, a basicervical fracture. It means the fracture is in the neck, but not in the middle part of the neck, the base of the neck. So this is almost an extracapsular fracture. The one on the other side here, this is in the mid part of the neck, so this is an intracapsular fracture. So treatment, you don't need to reduce this in the emergency room. No traction is needed. Patient needs surgery as soon as possible, ideally within 48 hours, to minimize the risk of complications like DVT and pulmonary complications. Patient should be on DVT prophylaxis from the beginning to minimize the risk of DVT. And all these patients should be assessed for osteoporosis after being treated for their fractures. So depending on the type, so if you have an intracapsular fracture, if it's displaced in an elderly patient, hemiarthroplasty, as we mentioned before. If it's non-displaced, you can fix it with screws, or the peg screws or dynamic hip screw. If the fracture is extracapsular, then reduction and fixation with plate or nail is indicated. This is an example of a plate. They call it dynamic hip screw. So it's a plate on the side and a screw that goes into the neck, and the fracture will be compressed because of the motion between the screw itself and the plate. So this is a dynamic screw, so it goes in and out to allow the bone to compress the fracture site. And this is an IM nail. There's no sliding in the IM nail, but it's more of a fixed angle device. This is a hemiarthroplasty for a displaced femoral neck fracture in an elderly patient. So the head was removed and then it was replaced with metal. In young patients, it's a different situation. As we mentioned, should avoid arthroplasty and try to do emergent open reduction and fixation. And this should be done within 6 hours, if possible, to avoid risk of AVN. Femur shaft, very high energy fracture associated with other injuries. Early fixation to avoid pulmonary complications is very important. Skin skeletal traction while waiting. IM nail within 6 to 12 hours is indicated. Tibial shaft fracture, also high energy, carries the highest risk of compartment syndrome because of the lack of soft tissue coverage, especially in the distal part. Carefully examine the skin, splint the patient after reduction. IM nailing usually is the best way of treating these simple mid-shaft fractures. Ankle fractures also are very common, can be classified based on the location of the fracture in the fibula. So Weber A is a very low fracture and stable ankle. Weber B, it's in the middle. It can be disrupting the ligaments connecting the fibula to the tibia, what's called the syndesmosis ligament. And Weber C is a high fracture, but however, the forces or energy will go through this fracture proximally and go down and disrupt all the connection between tibia and fibula, and then that will affect the stability of the joint. Also, you can have a bimalleolar fracture, means fracture also involving the medial malleolus. So if you have an ankle fracture, you have to reduce it if it's deformed like this. So this is most likely fracture dislocation, and then put a splint on it. Sometimes it's still subluxed, so you need to make sure that the joint is reduced, because a reduced or a dislocated joint is considered an orthopedic emergency and it has to be reduced as soon as possible. Treatment: if you have only fracture in the fibula, if the fracture is very low, Weber A, below the level of the syndesmosis ligament here, then this can be treated conservatively. So this is A here. A, this is conservative. B, this is questionable because this might be affecting the syndesmosis. But most likely this will need surgery. And C, this is usually surgical because most of the time it affects the forces goes this way, and then it affects the ligament. If you have a fracture here, it's called the bimalleolar. So this makes it definitely a surgical case. You need to fix both, this with screws and this with plate and screws. Any question?
يعطيك العافية يا دكتور.
الله يعافيك.